Okay, welcome back, everyone. Thank you again to all of our session one panelists. And we are now moving on to session two, which is really focused on survivorship. So I will keep the introduction brief, but to say that there are two really flavors of survivors. So according to the National Cancer Institute, you actually become a survivor on the day of your diagnosis. And so we have patients that are survivors that are actively receiving therapy. And then we have our long-term survivors. Now, we've of course always had survivors in melanoma, most of which were patients with clinically localized disease with stage 1 and stage 2 melanoma that had been clinically surgically resected. We now also, with the tremendous advances that we've had with immune and targeted therapy, now have a new generation of survivors. And so those are patients with stage 3 and stage 4 disease that have received these immune and targeted therapies that are now living for many years, either with minimal disease or without any evidence of disease. To start to address some of the unique needs of this population, we actually started a survivorship clinic specifically focused on patients with late stage melanoma who have been disease-free or off of therapy for now greater than 3 years. Our first speaker will be Michelle Rolfes, who will speak about our survivorship clinic. We've also, as part of this session 2, have invited speakers from across MD Anderson with unique expertise. So this includes, as I was alluding to earlier, Dr. Lorenzo Cohen, who directs our Center for Integrative Medicine. We also have speakers discussing financial toxicity, discussing neurocognitive function, and then uniquely actually adolescent and young adult survivorship. I'll give a little bit more of an introduction to each speaker as we come along, but I did want to go ahead and get the session started with Michelle Rolfes. Michelle is our lead advanced practice provider. So this includes basically our nurse practitioners and physician assistants that are our partners in care for our patients within the melanoma clinic. Michelle actually has her recent doctorate, and she is the clinical lead of our advanced melanoma survivorship clinic, and she'll be discussing that unique clinic today, which is, as far as I know, is actually the only such program in the US.
Thank you, Dr. McQuaid. I'm going to share my screen. Can everybody see my slides okay? And
we yes, can, Dr. It's in the, yep, there you go, perfect.
Is that better? Okay, can you hear me okay?
Yes.
Perfect. All right, so like Dr. McQuaid stated, I'm one of the nurse practitioners in our melanoma department, and I'm so glad to be able to talk about survivorship today. I've been caring for melanoma patients since the late 90s, and so I've seen a lot of changes over the years, and I'm very excited that we actually get to talk about melanoma survivorship, because back in the 90s and early 2000s, that's not really something that we were able to talk about. And also on a personal note, I have a mother who has lymphoma, and although she's finished treatment many years ago, it's really amazing how, just trying to get back to that normal and be able to establish a new normal after you've had a cancer diagnosis is pretty significant. And there's a lot of things that you don't even think about. And so I'm very happy to be able to talk about this today. So I want to first talk about a little bit, what does cancer survivorship mean? What is the definition for that? And then what is the difference between a cancer survivorship clinic? What do we do differently in that clinic versus other clinics that you may be, or other office visits that you may be used to attending? And then how do things change for you as you move from active therapy to this survivorship transition? and what can you expect. And then I'll talk a little bit about our specific clinic. Like Dr. McQuaid had mentioned, we've recently started up our melanoma survivorship clinic. And then any available resources that are out there for cancer survivors and their caregivers. So first of all, what is cancer survivorship? What does that mean? There's a lot of different definitions out there, and I will say that survivorship is different for everybody. Everybody has their unique experiences. They had different therapies, maybe they responded different to the therapies. They may have had different toxicities. So it's different for every person. I will tell you, these are the three main definitions. Whenever people think of cancer survivorship, they oftentimes think it's just meaning that you have no signs of cancer, you've finished therapy, and your cancer is gone. But it can also mean just having long-term stability of your cancer. As in the previous sessions, we've talked about all of the therapies that are out there for melanoma now, and we know that for some patients, we may still see evidence of their melanoma, but it's not changing, it's staying stable, and that actually is a good thing as well. So we can treat it more as a chronic condition. This last definition here is the most comprehensive, and that's what people think about is whenever you talk about cancer survivorship, it's living with, through, and beyond a cancer diagnosis. Survivorship does begin at diagnosis and continues throughout your lifetime. Saying that, I will tell you that for our survivorship clinics, we do focus more on the post-therapy and surveillance aspect of it. So people that are undergoing active therapy, they're actually being seen in their normal oncology clinics, and then once they've completed therapy and transitioned to more of the survivorship clinic, it's going to look a little bit different. Although the cancer survivorship and living with cancer is different for everybody, there is a common belief that life is definitely different after cancer. So why all this talk about survivorship? That we're actually in a good place right now. Like I said, I've been caring for melanoma patients for a very long time, and it's exciting to be able to talk about cancer survivorship, specifically melanoma survivorship. As you had heard with all of the amazing presentations earlier, we have come a long way with melanoma treatments over the past decade or so. These therapies have made a huge impact on survival of patients with melanoma. Cancer survivorship is, although we're specifically talking about melanoma, the National Cancer Institute has estimated that there's over 17 million cancer survivors in the United States. That's all different cancer types. So more and more people are living with cancer. Like I said, in melanoma specifically, we've made a huge impact on the survival of patients. These responses are long-term, and we're having complete responses with people that had metastatic melanoma, even with brain metastases. So we've come a long way, and these responses are not only happening, but they're happening for many, many years post-completion of their therapy. And I had mentioned earlier, even if a cure is not possible, many patients are staying stable. Even with, if we're still seeing disease, we may, they're still staying off the therapy and being monitored for a very long time. One of the things that we are trying to make sure that we focus on in survivorship is any long-term toxicities that we may experience from therapies. Although we've been giving these immunotherapies and targeted therapies for a long time, we're just beginning to learn of any long-term sequelae that may happen from these therapies. We do know that the worst of the side effects are whenever you're on therapy or shortly thereafter, but we do know that many months after completing therapy, you can still have a flare-up of any toxicity. So that's one thing that we try to monitor for in our survivorship clinic. So in a nutshell, survivorship is really just making sure that we're looking at the whole person. We are providing a holistic approach to care. We know that you have been through a lot. We do not want to overlook the fact that you've had a tremendous amount of stress. You've had a cancer diagnosis. You've been through therapy. That can be very taxing, both physically and mentally, on you and your caregivers. Quality of life is of utmost importance at this point in the road, and we just want to make sure that we're addressing a lot of other aspects that would typically not be discussed whenever you're in a busy clinic. According to the National Cancer Institute, many cancer survivors have admitted that once they completed treatment, it was very hard to be able to transition to that new way of life. You're having to adjust to new physical and mental changes. And so it's very important to have a comprehensive approach to your care. And that's what survivorship care is about. So the ultimate goal of survivorship is to provide comprehensive care to meet your unique needs. As clinicians, especially in the oncology world, our ultimate goal is to treat cancer and hope that it goes away and stays away. And however, we don't want to get tunnel vision and only focus on that. It's very easy for us to just think melanoma, and there's a lot of other things that you may be at risk for. So we want to make sure that we're not forgetting all of these other aspects of your care. But like I tell all of my patients, still our number one goal is to follow the recommendations for melanoma surveillance and making sure that we're looking for any evidence of disease recurrence, and if something were to pop up, that we act on that quickly. So still our number one goal is to follow the guidelines recommended for melanoma surveillance. So most of the patients I see are stage 3 and stage 4. Now that we're seeing patients a little quicker in the survivorship clinic because these immunotherapies have worked so well, I may be seeing them every 6 months or so, and then eventually transitioning to every year. But we're discussing, at what point can we go to that yearly surveillance? At what point can we start peeling off some of those scans that you're having to have done? At some point, we can drop the CAT scans or MRIs. And so that's something that we discuss at every visit. But it's also about other risk reduction. We know that patients that have a cancer diagnosis are at risk for other cancer diagnoses. So we don't ever want to forget about that. The dermatology exams, skin cancer screenings are very important for melanoma patients, as well as any patient, but melanoma specifically, and not just to check for other primary melanomas, but again, as we all age, we're at risk for basal cells and squamous cells. So skin cancer screenings are extremely important for our patients, but also the other age-appropriate cancer screening test. Colon cancer is rising in the United States, and in fact, we're seeing it in younger and younger patients. And because of that, the recommendations are now to do your first screening colonoscopy at 45 instead of 50. A lot of people don't know that. We want to make sure that they're doing this, and I'll tell you that our patients that are having CAT scans every 6 months or every year, they just assume that we're checking for colon cancer. They don't realize that that's not the best test to check for colon cancer. So I hear all of the time from my patients that, oh, I just assumed all of this stuff was being done. I assumed since I'm having all of this blood work done that you're automatically checking for these things. And it's not something that we automatically check for, but that's what we do in the survivorship clinic, is just making sure that we're addressing all of these other things. Prostate cancer for men over 40, and then lung cancer screenings for people that are smokers. We want to make sure that we're addressing that. And then in women, the breast and cervical cancer screenings with mammograms and pap smears. Lifestyle factors is very important and something that we really discuss a lot in our clinics. I always tell people it would be a shame to cure your melanoma and then you have a heart attack. And unfortunately, that is something that we see. It's very easy to just let yourself go. You've just been through a very traumatic experience. You've had therapy, and a lot of our patients just automatically gain weight. They just stop exercising. It's just it's one of those things that happens, and we just want to make sure that we're addressing the need to continue with good diet and exercise. And so cardiovascular health is very important. Sun protection is important, especially with our melanoma patients, and just discussing good sunscreen and wearing the long sleeve shirts, the wide brim hats when you're outside. So routine health maintenance is very important. We discuss this at every visit. Like I just talked about, the cardiovascular screening is very important, but other wellness screenings. And, like I said, again, we have this discussion and patients just automatically assume that we're checking cholesterol and we're checking hemoglobin A1C to, check for diabetes. And it's not something that we typically do, but it's something that we can definitely offer. And I do it in a lot of my patients because they may not have a regular physician. So it's all about screening and picking up on things that may be detrimental to your life. And it's all about having a good quality of life and living a long, healthy life. Immunizations is something that we discuss a lot, and this is, COVID vaccines, if that's something you're interested in, the recommendations for flu vaccines, pneumonia, shingles, tetanus, for example. Psychosocial needs are a big part of our survivorship clinic, and I'm going to talk about that a little bit more in detail. And we talked about treatment-induced toxicity. Like I said, a lot of our therapies, we may not see too much long-term toxicities, but range of motion and lymphedema is something very real for patients that have had lymph node dissections, and they may still need compression stockings. They may need help with physical therapy, so just helping to refer people to things like that. Some people have a lot of pain with neuropathy. We do have some patients that receive some chemotherapy, although that's not something that we treat very frequently for our melanoma patients. We do have some that received biochemotherapy many years ago and still have neuropathy. And then just other toxicities like we discussed. We have people that are requiring lifelong cortisol or thyroid replacements from their immunotherapies. And so just making sure that they're seeing endocrinology and other specialists that may be needed. So psychosocial needs, like I said, is a big part of the survivorship care. And we don't ever want to forget these things. It's very real. And, I have a lot of patients that are still battling some of these concerns, and there are going to be a few presentations after mine that are going to talk about more specifics of some of these. But like I said, you're probably not going to get back to your normal or your baseline as how your life was before you started therapy, but you're going to establish a new normal. How does that look? What can you do to make sure that you're having the best quality of life possible? Employment is a big thing, getting back in that workforce after maybe not working for months or a year or so. So finances is a big part of this. It is not cheap to receive cancer therapy. Rebuilding relationships is a big thing. It affects cancer diagnosis and therapy. It affects not just the patient, but the whole family. And really just the feelings of uncertainty about the future, coping with fears. I see it every time I see somebody that comes in for scans. They just, are looking at you, with paralyzed, just, not knowing what we're going to tell them. And, that's very normal. but we don't want people to just be so crippled with fear that they're going to recur, that they don't go out and have a normal, happy life. Anxiety and depression can be a long-standing concern for a lot of patients. So we just want to make sure that we're addressing this and getting people help that they may need. Legal issues and spirituality is very important and things that we should address as well. So to provide effective survivorship care, these are the 8 domains that have been identified that we need to make sure that we are addressing at each survivorship clinic visit. So we talked about anxiety and depression. Sleep disorders is a big one. I have a lot of patients that still suffer from insomnia, and just so trying to get help with that. Sexual function is a big thing, and it's something that most people don't want to discuss, or they're embarrassed to bring it up. So as providers, we need to make sure that we're addressing this, and if not, then feel free to please ask about that. Pain, we talked about immunization. Fatigue is a big one. It's one of those lasting complaints that a lot of people have, and just trying to, what's the best way to manage the fatigue so that you can continue to perform all of the activities that you need to perform. Exercise and diet, we talked about that. Cognitive function is a big thing. We have a lot of patients that had brain metastases that may have had surgery or radiation, and they have some memory loss. And so we want to make sure that we're addressing this and then getting people the help they need. I refer people to our neurology department if they need more help with this for neurocognitive testing. So one way that we can make sure that we're identifying all the needed elements in your care is to have these survivorship plans, which is just your personal passport to survivorship. So your survivorship plan is going to include your personal patient information, which is your cancer diagnosis. What type of melanoma did you have? What was your stage of melanoma? Where was the melanoma? Where was the primary? Where did it metastasize to, if it did? Who is your medical team? That's not just your medical oncologist, but also who is your surgeon, your dermatologist, your endocrinologist, if you're seeing an endocrinologist. And then your summary of cancer treatment. What did we do about the melanoma? Surgery, radiation, immunotherapy, etc. And then other treatment or tests that are recommended. For example, if you have lifelong endocrinopathies, hypothyroidism from your immunotherapy, we want to make sure that we're addressing that every time we see you. Your after treatment care, again, that's just your follow-up appointments, what tests are needed, at what point can we take those off, any other long-term issues, emotional and social issues we discussed, and any other advice from your care team and any community resources that are available. So this is just some examples of some of the advice that we may give you. Again, we talked about screening tests and eating habits, exercise. We do give out, although we always discuss this verbally, we have great literature that we give patients and their caregivers about good, healthy eating, healthy weight programs, exercise. We talked about the sunscreen, immunization, smoking and tobacco cessation is a big one. We discuss that at every visit. Sleep, we talked about preventing osteoporosis. I didn't mention, but that is something that we discuss, as well as any complementary or alternative medicine if that's something that you're interested in, and counseling if we feel that that is something that is needed. Then we definitely can refer to that. And then any support groups that are out there. So just briefly, I just wanted to mention, like Dr. McQuaid had said, we recently resumed our survivorship clinic. Unfortunately, we had to let ours go a few years ago just because of staffing and everything, but we really have a need for survivorship clinics. We have a lot of patients that are not on active therapy that are doing great, and we wanted to be able to resume this clinic so that we could give them everything that they need to address all of these things that we talked about, because we are able to spend a little bit more time with our patients in this clinic versus a busy oncology clinic. So we did resume our clinic back in September of 2020. Currently, we're only doing this one day a week on Thursdays. Surgical melanoma surgery has a survivorship clinic on Fridays. We are partnering with our dermatology colleagues. Hopefully, at some point we can do virtual visits, but right now we're trying to do everything in person, because for melanoma patients, it's very important that they're having a good skin check and lymph node check at every visit. So if they're not seeing a dermatologist at MD Anderson, then we at least wanted to see them in person at our visit. We are seeing mostly stage 3 and 4 patients that have been off therapy, have been either free of disease or have stable disease for 3 years, and have been off therapy for a year. I do see some stage 2 patients as well, but those patients are typically followed by melanoma surgery. And this is just some community resources that I wanted to show that are available. American Cancer Society is a great resource. Cancer.net, Cancer Care, Cancer and Careers is good. Again, we had talked about entering the workforce again. That's a great resource. The Cancer Legal Resource Center, the National Coalition for Cancer Survivorship, as well as Psychology Today. And that is all I have.
Great. Thank you so much, Michelle. And that was a really comprehensive introduction to the holistic care that we aim to provide to our melanoma survivors. As Michelle mentioned, survivorship starts actually on the day that you're diagnosed. And so in our next few speakers are going to dive a little bit deeper into some of those specific domains in the active care setting, as well as in the survivorship, long-term survivorship setting. So first up will be Dr. Jeff Weffel. He is a professor of neuropsychology here at MD Anderson. He conducts research on the cognitive effects of cancer therapy, which again has traditionally been chemotherapy, and now very excited to actually partner with Dr. Weffel about actually examining cognitive effects of immunotherapy as well. Dr. Weffel, if you want to go ahead and share your screen.
Thank you. Unfortunately, my camera is not working. This is a technology failure. I apologize for that. I assume you all can see the screen at this point?
Yes, it's in the preview mode. If you could switch it to the. There you go. Perfect.
Okay, wonderful. Well, thank you for inviting me to be with you here this afternoon. I appreciate the opportunity to speak to you a little bit about cognitive function and some of what we've learned about cognitive changes in cancer patients, and also provide you with some information about what you can do with some of the changes that you may be experiencing. Often when I can see everybody, I like to ask, for a show of hands to see how many people may have experienced some of these changes. We don't have that opportunity together today, but I'll presume that at least one person in the audience has experienced some changes here. Okay, so as by way of some epidemiology and introduction, I think you all probably know that there are many different cancers. Melanoma is a fairly common one. Much of what we've learned about the cognitive changes in patients with cancer who have non-central nervous system cancers, cancers that are not in the brain, come from the study of women with breast cancer. But we are increasingly studying individuals with melanoma and learning more kind of week by week about this. In 2020, the worldwide incidence of cancer was over 18 million. And by 2024, the number of cancer survivors in the USA is estimated to be 19 million. And by that same date, we estimate that there'll be about 6 to 13 million cancer survivors with cancer-related cognitive decline. So this is not an uncommon experience or phenomena. So if you are experiencing this, you're not alone. With the improvements in cancer survival times that have been experienced by malignant melanoma patients and many other cancer patients, this has led to an increasing number of cancer survivors in the United States and globally. And this has allowed us and encouraged us to focus more attention on cancer survivorship and a number of the issues that accompany that experience, as you just heard earlier, and cognitive changes can be one of those as well. The Livestrong Foundation in 2012 surveyed about 2,300 adult cancer survivors, And you can see it was very common to report fatigue and difficulties with cognition. But we also know that identification and management of these issues are often very infrequent. There are a number of different things that can lead to and contribute to cognitive changes in cancer patients. And I've kind of drawn this cartoon here to go over a number of these things. On the diagnostic phase, location here really refers to a brain tumor location. So when we have a tumor in the brain, there can be a specific set of cognitive deficits that arise from the specific part of the brain that's being impacted. We also know that our germline genes, those genes that we're born with, can modulate the experience of toxicity. There are molecular features of cancers that also seem to interact and produce certain vulnerabilities to cognitive dysfunction. And then we know things like brain reserve, brain resilience, and cognitive reserve also can impact the extent to which we experience cognitive changes after our cancer diagnosis and treatments. Treatments can include surgery, radiation chemotherapy, adjuvant chemotherapy, immunotherapies, targeted therapies, all of which have the potential to impact cognition. And of course, we experience medical comorbidities, we receive a lot of medications, we have psychological distress. All of this also can potentially contribute to the experience of cognitive changes. And those cognitive changes impact our daily life, our life at home, our life at work, and our social lives. So as I said, there's increasing knowledge, awareness, and scientific evidence that these chemotherapeutic and targeted therapies, the immunotherapies that we receive, brain radiation therapy, and affective distress and fatigue can all lead to brain changes. These have been documented on MRI with findings such as gray and white matter alterations, disrupted network brain organization, functional activation abnormalities. And all of this is associated with cognitive dysfunction, changes in our memory, in our reasoning and decision-making, our thinking speed, our attention. If we dive into the immune checkpoint inhibitors, which have transformed the management of melanoma, we know that toxicity can occur across many organ systems. I believe you've heard a bit about this already today. And as many of you may know, skin toxicities are frequent. We can see a very large blue circle indicating that this is a more frequent occurrence, but a small red circle here indicating that the severity of that toxicity is often mild. Whereas CNS, central nervous system, or brain toxicities are infrequent, but when they happen, they tend to be severe. And these tend to occur within 4 months of treatment and involve things like encephalitis, demyelinating disorders, headaches, confusion, stroke, muscle weakness, neuropathies, and endocrine system dysfunction. And now we've recently had some preclinical mouse models that are looking at these ICI therapies, and they've demonstrated that they can have untoward effects on brain and behavior, leading to cognitive impairment, mood disturbance, and inflammation. A recent neuropsychological study was published in Survivors of Immune Checkpoint Inhibitor Therapy, on average about 2 years after completing treatment. And what they found here was cognitive dysfunction in a large percentage of these patients. In 44% of the patients, there was also evidence of affective distress, symptoms of depression and anxiety in over a third of the patients, and clinically significant fatigue in this population. So we know that survivors can be experiencing multiple symptoms simultaneously. So how do we go about trying to maximize cognitive function in this context? Well, we've studied radiation therapy to the brain and found ways to mitigate the toxicities of radiation therapy. And I'm going to show you just 2 examples of that. In a study that took patients with 1 to 3 brain metastases who in the past, about 20 years ago, were treated almost uniformly with whole brain radiation therapy, we asked the question whether or not we could use stereotactic radiosurgery to just deliver a focal radiation therapy only to that lesion that we would see. And what we found is if we use that focused approach without whole brain radiation therapy, there is far less neuropsychological deterioration, less memory loss than if we combine the focal approach with the whole brain radiation therapy. So this transformed one of the standards of care for radiation therapy to try to be more focused when possible. However, we know there are situations when there are many brain metastases and whole brain radiation therapy is a preferred approach. And in that context, we wanted to understand whether or not we could protect the brain with a medicine, specifically with memantine. So we designed a clinical trial in which patients with many brain metastases were randomized to whole brain radiation therapy, either with memantine, the neuroprotectant, or with sugar pill, with a placebo. And what we found was that memantine delayed the time to cognitive decline. So it seemed to provide some degree of protection when you're receiving brain radiation therapy, specifically whole brain radiation therapy. We also, in that study, were able to identify that there was a gene that we have a germline gene. So we're born with these genes, and some of us are born with an E4 allele, and some of us do not have an E4 allele. But if we have this allele, this single nucleotide polymorphism, we are at greater risk of cognitive toxicity when exposed to whole brain radiation therapy. So now we're identifying ways that we may be able to start evaluating patients and consider ways to personalize care to not only treat tumors, but also protect brain and cognition. So that's well and good, but what can we do today, maybe in our daily lives? And I think this is a very nice graphic about all the opportunities that we have across our lifespan to help maintain our brain health and prevent worsening of cognition as we age. And in early life, a lot of the things that we can do involve strengthening our brain and educating ourselves. In mid to late life, it's taking care to address things like hearing loss, trying to quit smoking or not smoke, address depression, physical inactivity, social isolation, hypertension, obesity, and diabetes. And if we combine all of those opportunities to modify our outcomes, about 35% of the outcome is potentially modifiable and in our own hands. So similarly, the Cleveland Clinic Foundation has come up with what they call the 6 pillars of brain health. And this is good advice for every one of us on this call. They involve doing things each day, like getting moving, with the recommendation being, at this point in time, being about 150 minutes of moderate or 75 minutes of vigorous activity per week. In addition, strength training 2 times a week if possible. This would be an optimized physical activity schedule. Eating well, and I always say talk to a dietitian, but generally speaking, they're talking about low-carb diets and Mediterranean diets and avoiding saturated and trans fat and added sugars. And of course, if you're on one of Dr. McQuaid's studies, I would say make sure you stick with her program. Controlling other risks like blood pressure, cholesterol, avoiding smoking and moderating alcohol intake, ensuring that we get adequate rest and that we manage our stress levels, and then staying mentally active, remaining curious, learning new hobbies and skills, and playing in ways that we engage our brain. And it's very important to stay connected to others, to maintain our interactions with our social community. This will insulate against stress, and really those conversations are also very brain engaging and stimulating. When you see your physicians, they oftentimes will look to see if there are reversible contributors that may be causing or contributing to some of these cognitive deficits. They may do some blood work and look for metabolic abnormalities. They may review your medications and make sure you're not taking unnecessary medications that might have anticholinergic properties, which are oftentimes challenge cognitive function, or that you're not on overly sedating pain medications. And of course, we'll want to evaluate and treat mood disturbance if we find this. And then, as you had heard before, there may be referrals to experts in this area like neuropsychologists who, through their evaluation, can then develop personalized intervention plans that could include things like cognitive rehabilitation. One example of this would be memory and attention adaptation training. Or they could help you develop compensatory strategies and implement and use cognitive prostheses to minimize the impact of these cognitive deficits on your daily life. Through that evaluation, there may be opportunities to identify pharmacotherapies that may be beneficial in either improving or delaying some of these adverse effects on our cognitive function. Psychological interventions and supportive care interventions are oftentimes identified as need areas, and we try to arrange those for patients when necessary as well. You can go to the following websites, and I understand that the slides will be available to you, so if you don't have an opportunity to write all these down, I appreciate that. But the NCCN survivorship guidelines, cancer.gov, cancer.net, and MD Anderson all have more specific strategies for helping with cognition. I mentioned before that fatigue and sleep disturbance are frequent in the cancer survivorship group, and cancer-related fatigue has been defined by the NCCN as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer that is not proportionate to recent activity and interferes with usual functioning. And we can see that melanoma survivors are more likely than individuals without melanoma and individuals without cancer to report chronic fatigue. And this is also true across a variety of other cancer populations. It's probably one of the most prevalent symptoms in a cancer hospital. And as you can see here, symptoms such as fatigue are reported by the vast majority of cancer survivors as occurring at least a few days each month. For many of them, they're saying it's occurring every day. Many others saying most days they experience this. And this is more frequent than nausea, depression, and pain in this surviving population. So things we can do to manage fatigue is identify and treat any potentially underlying correctable medical conditions, and then regular exercise, sensible diet, activity scheduling, and energy conservation so that you prioritize the things in your day that you want to get accomplished. And then if many of those approaches don't work, there are opportunities to consider some pharmacotherapies, things like stimulants that may be beneficial for patients, and you speak with your physicians about that. Sleep disturbance is also common. We would like to try to target 7 to 8 hours of sleep per night. And very often I find when I work with patients that they may not be following all traditional sleep hygiene recommendations, which include things like instituting a consistent sleep schedule, trying to initiate sleep and wake up at the same time on a regular basis, limiting vigorous activities and caffeine before bed, making sure that your bedroom is kind of proper conditions, dim lights, unplugged from your electronics, do a little relaxation before attempting to go to sleep. Make sure your bedroom is comfortable, the temperature is cool and not too cool, not too hot, that the lighting and noise have been addressed. And then use a 10-minute toss and turn rule. So if we're not able to initiate sleep, then we need to actually remove ourselves from the bed in the bedroom. Again, return to trying something that's relaxing and calming, and then return to bed and start over on this cycle. And try not to replace sleeping at night with daytime naps. We also seek to identify any of these modifiable medical contributors. For example, we may be taking activating medicines at night, and perhaps it's possible to take those in the morning instead. And then ultimately a sleep study if there are problems. This graphic on the right shows some data that was exploring the effectiveness of cognitive behavioral therapy for insomnia versus versus a stimulant drug to address fatigue. And what they found was that CBT improved fatigue symptoms more than the stimulant medication. And it did this because it was addressing these sleep disruptions, this insomnia pattern. And so I think it's really important for us, even if we're tired, to really think about how are we sleeping, and that might be the key to many of these difficulties. We also know that exercise is medicine. Unfortunately, we know that only approximately 1/4 of cancer survivors get the suggested amount of activity each week, and over 50% report no moderate to vigorous activity. And as you can see here in this graphic, if you are active, your hazard ratio for cancer mortality is lower. But if you're insufficiently active or inactive, then your risk of mortality or risk of death from cancer increases. So that's why there's a lot of emphasis on making sure that we're moving and exercising as much as possible. We also know that exercise helps a lot of things. So for people with cancer, even in their survivorship period, exercising can reduce cancer-related fatigue, improve health-related quality of life, physical function, anxiety, depression, sleep, lymphedema, and bone health. And we also know that there is at least preclinical evidence that exercise through increasing cerebral blood flow and through stimulating neurogenesis can improve cognitive function and enhance memory function. So we know cognitive dysfunction and fatigue are common. It's important to discuss these issues with your healthcare team. Request a neuropsychological evaluation, which can help define the cognitive disorder and develop a personalized treatment plan. And interventions are available to minimize the impact of these issues on your quality of life, your function, and your survivorship. So with that, I thank you.
Thank you so much, Jeff. I think it's one of the things that just really strikes me is the fact that we come to basically these same types of lifestyle recommendations in terms of both decreasing our risk of second cancers or of other comorbidities, as Michelle spoke about, as far as improving cognitive function and decreasing fatigue, as Dr. Weffel just spoke about. And then I will now introduce Dr. Lorenzo Cohen, who will actually also touch on how these domains actually might decrease risk of recurrence, decrease risk of cancers, and improve outcomes. So as alluded to earlier, Dr. Cohen is actually the director for the integrative medicine program here at MD Anderson. I'm sure he will share. He is also actually a melanoma survivor himself as well that was treated here at MD Anderson. I've actually known Dr. Cohen for over 20 years now. He was actually my mentor doing integrative medicine research actually before I ever went to medical school. So Dr. Cohen, I'll let you go ahead and get started.
Excellent, thank you. Thanks for having me with the group today. Let me, I don't see my talk here open for some reason. Hang on. Here we go. So as Dr. McQuaid mentioned, I'm the director of the Integrative Medicine program here at MD Anderson, and I will try and take us through a bit more detail on some of the things that you just heard from the previous two speakers in reference to some lifestyle factors. And as you may have seen in the Q&A in the chat, trying to get a little more prescriptive on what we can recommend for you in certain areas. A lot of what I'm going to discuss today comes from this book that I wrote with my wife called Anti-Cancer Living, Transform Your Life and Health with the Mix of Six. And I put it up here more for financial disclosure, not necessarily to have you go out and buy the book. But we only have 15 minutes. And so there is so much information, is so much I'd love to share with you. So more information, of course, is available here. As Jennifer mentioned, and interestingly, literally on the day that I finished writing this book, which is all about cancer prevention and the same recommendations for control, meaning once you have cancer, to try and improve not only quality of life, but length of life. On literally that same day, I was diagnosed with melanoma. Another somewhat coincidence was that exact same day received an email from the Melanoma Research Alliance that our grant to study melanoma and lifestyle was funded. Interestingly, my melanoma was discovered as a unknown primary swollen lymph node in my axilla. And so on that day, we didn't know that it was melanoma. We knew it was malignant and they were cancer cells, but it took a few days to figure out that it was melanoma. And of course, all the signs had been pointing to that based on these coincidences. For those who English isn't your first language, this book is also available in other languages. So what is the mix of six? Well, you've heard discussion of some of these this morning. So we start with love and support, managing stress, sleep and ensuring that we have healthy sleep, exercise, diet, and decreasing our environmental exposures, toxins. Of course, one primary environmental exposure that many of us have had is excessive sun exposure, which is the #1 risk for melanoma, and why melanoma is on a precipitous rise in our country, because those of us who had all this unhealthy sun exposure as youngsters, when we didn't protect ourselves from the sun, now have those cancers essentially appearing. So the damage was done years ago when we are children, and the key is to try and make our bodies as inhospitable to those mutated cells to grow and ultimately threaten our lives with this disease that we call melanoma, and of course many other diseases. Cancer takes, usually a very long time to grow, and so this is something where engaging in what we call the mix of six to help our body be as strong as possible. Something very important that needs to be realized is that there's an interrelationship between all these factors. So not only will these factors in and of themselves influence cancer risk and outcomes, but they influence each other, and you all know that. So when you have a poor night's sleep, you're not as interested in engaging in exercise. There's evidence to show that sleep loss will lead to cravings of what we could call comfort foods, which are really high fat and high carbohydrate foods. We know that sleep loss actually, as well as stress, changes the way our body metabolizes food. So if we think, I want to lose weight, I want to get healthy, I'm just going to focus on exercise and diet, Yes, those are important components, but if you don't also focus on your sleep and your stress management, those changes aren't going to be as healthy, as well as it will be harder to maintain some of these lifestyle changes. So the more that we can capitalize on the positive effects of synergy, the benefits of a good night's sleep, that managing your stress will allow you to make better dietary choices, etc., the more successful we'll be in all of the areas. It's also important to know that these 6 factors that we've focused on influence not only how we feel, but how our body behaves at a biological level. And here you see a pictorial representation of what's called the tumor microenvironment. The tumor microenvironment, which is where the cancer is growing, is innervated by multiple biological processes. And these lifestyle factors influence one, and in many cases, all of the biological processes that need to be in place to stop a mutating cell to grow into a mass and develop into something that we call cancer. One way of thinking about these biological processes has been described in a seminal paper now dating back to 2011 called the Cancer Hallmarks. But simplistically, these are the biological processes that exist within our body that is supposed to stop that mutating cell from replicating. So the cells are mutating all the time in our body. And the key is that these processes are there to keep things in check. And what happens when these cancer hallmarks are activated, that mutated cell can avoid immune destruction. It can set up its own vascular system. These cells that are not supposed to function well when they leave that particular part of the body actually activate processes that allow them to break off and move forward. So the key, and we'll talk about some of the details in there, is to establish lifestyle behaviors that will make us as resilient and strong as possible. We don't have time to get into all of the mix of 6 today, but I'll touch on some of the most important areas. We start with social support, and we can talk more about that in the Q&A, because if you don't have the supports in place, it's very hard to make some of these difficult lifestyle changes. So starting with stress, why is stress so important? Well, stress initially impacts, of course, our brain. Our brain is in control of all biological processes in our body. And when we respond to a challenging, difficult situation in our environment with this fight or flight response, on the one side, it can be beneficial because it allows you to mobilize resources, it prepares you for this event. But when that event becomes chronic and unremitting, and we're constantly in a state of fight or flight with these stress hormones flooding the body, this can be extremely unhealthy. And we know, in fact, that chronic stress activates all the cancer hallmarks, meaning it decreases immune function, it increases inflammation, it actually increases angiogenesis. Chronic stress allows processes to take place where the cancer can grow its own vascular system better than an individual who isn't chronically stressed. And stress is damaging to such a degree that it literally gets into the nucleus of every cell and leads to something that's called telomere attrition. When you see pictured there, chromosomes, and on the end of every chromosome in our body are what are called telomeres to help maintain the structural integrity of the chromosome. And chronic stress leads to telomere attrition, which means that when the cells replicate, there's a higher propensity those cells are going to mutate. Something interesting is that telomere attrition happens just as we age. And in fact, historically speaking, of course, cancer is primarily a disease of more advanced age, which unfortunately is not the case anymore for multiple reasons. Chronic stress leads to telomere attrition. So essentially, chronic stress is speeding the aging process. And this, of course, is something that we need to manage and to try and get a handle of. So, this doc is saying to a patient, stress is killing you. You just need an easier job, a smaller house, and a different family. Well, those of you who are parents and have families and houses, you probably know this is actually probably pretty good prescription, but not something really realistic that we can recommend to patients. There is a whole plethora of things that we can do to manage stress. And many of you may have seen this and heard about these different mindfulness-based approaches, but there's also conventional approaches. And Dr. Weffel referred to, as well as prior speakers, to cognitive behavioral therapy and group therapy, psychotherapy. And then, of course, there's these different relaxation types of skills and more formal programs. Somebody mentioned in the chat about painting, and there's other forms of expressive art. Essentially anything that can help to decrease that sympathetic nervous system activation, that acute stress response from becoming chronic, is going to be helpful. And the evidence base is extremely deep and broad for a lot of these types of practices, like meditation, hypnosis, expressive writing, yoga, tai chi, qigong, again, CBT, and other forms of conventional therapies. And not only do they help us feel better, decrease anxiety, depression, but they have a profound impact on our biology. And there's evidence to show that mindfulness-based stress reduction programs actually lead to a slowing down of telomere attrition, just as one example, better stress hormone regulation, and improvement in immune function. Now, although meditation moments can be very useful, ideally you're engaging in some type of a mind-body practice for more than just 2 or 3 minutes. But taking 2 or 3 minutes every day at moments throughout the day is something that is extremely important. So although setting aside that time, 10 minutes, 20 minutes, an hour on the yoga mat, proverbially speaking, it's important to also take mindfulness off of the mat and into your everyday life. So I'm just going to quickly go through this just to highlight. This is the National Comprehensive Cancer Network guidelines for managing symptoms, and others have reviewed this as well. But listed here, this is for helping to control nausea, are many different behavioral programs that are accepted and should be recommended as part of the standard of care for nausea. For fatigue, here you see physical activity, yoga, massage, of course, psychoeducation, CBT, and then some other strategies that don't quite have as much evidence as those top ones. For pain, here you see a lot of the behavioral strategies, as well as things like acupuncture, TENS, and other strategies. Of course, for distress management, as I mentioned, a lot of the behavioral programs, as well as recent recommendations to consider yoga for other symptoms like cognitive functioning, menopausal symptoms, and pain. So this one person saying to the other, I've had a lot of free time this year, and we all have had a lot of free time, but we often don't choose to spend our time on ourselves and managing stress. So it doesn't take long, and it's something that is just critical. I'm not going to talk much about exercise. Dr. Weffel described that essentially exercise it's just so fundamental. It's so critically important. In my own case, I had been studying cancer-related fatigue, but hadn't experienced it until I underwent immunotherapy for melanoma. And it was quite shocking when I first experienced cancer-related fatigue. And I thought, I just got to get up the driveway and throw myself on the couch. And then, the other scientist part of my brain was activated and said, no, exercise combats cancer-related fatigue. So, I got the dog and the leash, and started to force myself to walk around the block, and halfway around the block, the fatigue actually in that situation at that point started to lift. And so, exercise is, as you saw on that previous slide, just critical. Exercise also influences every single one of the cancer hallmarks, making our bodies less hospitable to cancer growth. And there's clear guidelines for exercise. Somebody asked in the chat about high intensity interval training. Well, it doesn't have to be high intensity. You don't have to run a marathon. You just need to move on a regular basis. And you see some of the recommendations here. It's essentially 30 to 60 minutes of physical activity a day. Ideally, you're doing it every day, and you see the most recent recommendation there that even getting more than that hour a day leads to improved health benefits. And you see all the benefits listed there for improving aspects of quality of life, not the least of which, as was mentioned earlier, decreasing your risk for other non-communicable diseases that we're all vulnerable to, like diabetes, heart disease, etc. So let's get into diet a bit. I mean, diet is we could spend an afternoon just talking about the importance of diet and the evidence. This is just one example that is focused across multiple countries around the world, trying to pull together this data. And the evidence is pretty clear now that diet will influence, again, back to all of the cancer hallmarks. And it's important to understand this because it's not just about weight and about being healthy on the outside. It's really important to understand that it innervates all biological processes in our body. So you've probably heard about all these different diets, and somebody asked in the chat about plant-based diet, and this one line is saying to the other, I'm trying to eat more vegetarians, and you don't necessarily need to be a vegan or a vegetarian, but we need to have what's called a plant-centered diet. And ideally in anti-cancer living, we talk about the 90-10 rule, which is that ideally 90% of your plate is filled with health-supporting foods, predominantly vegetables, a smaller portion of fruit, importantly whole grains, beans as a source of protein, legumes, nuts and seeds as another source of protein. And then if you do eat animal foods, making sure that they are from animals that are healthy, and that not be your sole source of protein, but you can also get protein from the plant world. We also know a lot about the microbiome, and the microbiome in particular in melanoma is critically important. And a lot of this evidence has come from Jennifer Wargo, Jennifer McQuaid, my laboratory, specifically in the area of melanoma. And we just published a paper at the end of 2001 that looked at patients with melanoma and did a survey about their diet, also other lifestyle habits. This is the grant that was funded on the day that I was diagnosed with melanoma. And we looked at the report of how much fiber individuals had in their diet. And we're able to clearly show that the patients who had high fiber diet had a higher probability of response to treatment. And as you can see here, greater probability of long-term survival. And this was really just a 35,000-foot view of fiber in the diet. We recapitulated that actually in animal studies, and were able to show and understand the mechanisms further. Interestingly, and somewhat of a surprise to us, we also assess probiotics and the use of probiotics because there's the belief that, if the microbiome was really important, well, I'll take these probiotics off the shelf to improve my microbiome. And in fact, what we saw is that individuals who are on probiotics had less biodiversity, which is what we're looking for within their microbiome. And the individuals who weren't eating fiber as well as having consuming probiotics had somewhat the worst outcomes. And you can see here, it's the individuals with sufficient fiber and not taking a probiotic that had the best outcomes. After my diagnosis, I was concerned about the types of food I was eating, and I was particularly concerned about eating too many whole grains because of the concern of the link between high carbohydrate foods, glycemic load, inflammation, immune suppression, etc. So I actually decreased some of the whole grains that I was eating, and I increased the amount of these probiotic foods. And I kind of described the story in more detail, those who want to take a look in this Wall Street Journal op-ed. And what I learned and what we learned about some of these probiotic foods is they are also somewhat limited in the bacteria that they contain. So there is no substitute and there is no quick fix. The key is really to eat high fiber foods, primarily a plant-centered diet, and to try and have a mixture from multiple food groups at each meal. So this is the basic prescription within the mix of 6. We didn't get much into sleep, but Dr. Weffel mentioned that the 90-10 rule, exercising on a regular basis, and that it takes time, and that we need to be compassionate and have self-compassion for our practice, because it is a practice, and the more you practice, the better you'll get. And with that, I will stop sharing.
Thank you so much, Lorenzo. Quite a tour de force and a lot of information that was covered. Just to put a plug out there, as we are following up on our study showing that patients that are habitually consuming high fiber have improved response to immunotherapy. We actually have ongoing clinical trials of interventional feeding studies where we actually give patients food and see, can we actually change the microbiome if we change diet? Please continue to put questions in the chat. And again, I apologize for going out of order, but next we're going to move to Dr. Grace Smith, who's going to be speaking about financial toxicity. Now, Dr. Smith is actually an associate professor in radiation oncology. She is a radiation oncologist and specifically GI radiation oncology. So why is she speaking in our forum? And that is because she also has a master's in public health and PhD specifically around these issues of financial toxicities and the financial burdens that many of our cancer patients unfortunately suffer from.
Good morning. Thank you so much for the opportunity to speak today about the financial impact of cancer. I'll go ahead and share my slides. And I'm just trying to make sure I can advance them here. I have no disclosures. But I do want to thank the patients and survivors, many of whom have contributed their voices to our understanding of the financial impact of cancer care, including many quotes throughout this talk today. My objectives today are to define the concept of financial toxicity and then to discuss the current strategies to reduce this problem that's so impactful on patients, their caregivers, and families during treatment and across survivorship. What is financial toxicity? It's really a new and emerging term, but quite simply, it's the burden of costs from the patient's perspective. So many in this audience could be familiar with the financial impact of cancer care from an entire healthcare system perspective. And this figure is adapted from a recent publication showing the ever-rising spending on cancer care in the US. It's about $200 billion annually. The US healthcare system's cost burden from cancers has been driven by increasing prices of both cancer-related medical services and drugs over the last decades, and it continues to rise. But the term financial toxicity refers to a related but distinct concept. It's the patient's perspective. So it's the patient's view on how the costs of disease and treatment impact them and their caregivers, their households, and their families. And we hear this in many patients' own voices. How am I going to pay these bills? It's not just the bills, though. It's the financial burden shouldered by cancer patients, not just through out-of-pocket medical spending. It's really more than that. It's about being depleted. In patients' own words, my premiums have tripled over the past 4 years, tripled. And then now, of course, the savings is just about depleted. Underneath the surface, there are many aspects of financial depletion that patients face. From the patient's perspective, there are the obvious financial burdens from out-of-pocket spending on medical bills, health insurance, and prescriptions. But underneath the surface, there's the draining of patient savings, and then the sacrifices and economizing that patients engage in to afford care to cope with the effects of disease and treatment itself, and potentially related disability. From giving up leisure spending to lost work and income temporarily or permanently, to foregoing food or housing, to the inability to continue caring for dependents. These are the many components from the patient perspective that weigh heavily on their financial burden related to cancer. And there's also psychological distress from these financial stressors. And these are really the domains and dimensions of financial toxicity that patients and survivors of cancer have elicited as key to their experience of this problem. For some patients, this impacts basic needs. We literally had no cash on us. I ended up finding later in my purse a check that a client had written me for like $45 that we were ecstatic about because I was able to cash and go get something else to eat. For other patients and their families, financial toxicity truly brings them to the brink. We were on the brink of, when all is said and done, we were on the brink of declaring bankruptcy. How frequently does financial toxicity have an impact? My research team's prior published analysis identified that about half of cancer patients and survivors experience an aspect of financial toxicity. Financial toxicity, according to patients, tends to peak during actual active treatment, but a substantial portion of survivors, even long-term survivors, feel persistent financial burden and impact even years beyond their initial diagnosis and treatment. And I think this is really important to voice and recognize, because this is a problem that's impactful from diagnosis and during treatment, but all throughout cancer survivorship. And the reason talking about financial toxicity of cancer is important is that its frequency rivals and sometimes exceeds the common physical toxicities of cancers that we've already been talking about today: lymphedema, chronic fatigue, chemobrain, cardiotoxicity, neuropathy. So financial toxicity is truly a critically important problem to recognize as a component of many cancer patients and survivors' whole cancer journey. Individuals who are at risk for financial toxicity are younger, of minority race or ethnicity, have lower income or unemployment, or lacking or under health insurance. Risk factors related to an individual's disease characteristics have included more advanced cancer stage or recurrent disease, receiving chemotherapy or systemic therapies, or receiving multi-modality care, such as combinations of surgery, chemotherapy, targeted or immunotherapy, and radiation therapy. So why is there cancer-related financial toxicity? Well, cancer care is expensive, we know that, but the side effects, toxicities, and symptoms from treatment are also very costly to manage. And treatment is time-consuming. and this interferes with patients' ability to work and care for their dependents. The multimodality nature of cancer treatment, so including the surgery, chemo, or targeted immunotherapies, radiation, and long-term maintenance therapies, combined or in sequence, is complex, it's time-consuming and costly. And care is frequently specialized, potentially limited geographically, and this can require patients to travel and add further housing and transport resource costs to access this care. And finally, I want to mention that the trajectory of cancer involves uncertainty, with changes in prognosis, complications, or relapses in disease that can prolong these above costly aspects of care. I didn't have anything because I thought I was going back to work. I'm thinking, hey, I can tough this thing out and eventually I'll be going back to work soon. But treatment took a little bit longer than what I thought. Everything is stretched out. This discussion of financial toxicity continues to become only more significant and more relevant in the current era of cancer treatment. Novel oral and infusion therapies, including targeted and immunotherapies, have dramatically changed the landscape of treatment and outcomes, including for patients with melanoma. And so from a disease outcomes and survival perspective, this is truly heartening and exciting. At the same time, these novel developments have a price. Directly relevant to patients with melanoma, the cost of therapies, especially oral cancer therapies, is unrelenting. This was a recent study of the price of oral cancer therapies, and it showed that the average price of oral cancer therapies in the US is about $11,000 per month. So from the cancer patient's perspective, insurance might cover some of this, but still the out-of-pocket cost burden is substantial from patients' perspective. Having health insurance doesn't entirely mitigate the problem of costs, including drug costs. And this is exemplified by this concept known as the donut hole in prescription coverage that Medicare beneficiaries encounter, with a large gap in coverage and out-of-pocket costs up to $7,000 per year under Medicare, until individuals finally reach a catastrophic coverage. And even after that, individuals still need to pay copays for the rest of the year. I underscore this to show that this is a large and long-term problem for patients. It's not going to go away, especially for patients who are receiving oral cancer therapies, because the rising prices of oral cancer therapies continues to outpace the rate of inflation. And this was demonstrated in a recent publication by one of our colleagues here at MD Anderson, Dr. Tina Shi. There was also a recent survey of patients with melanoma treated with immunotherapy, and this identified several specific areas where respondents felt most financially stressed. About 1/3 or more felt that they had no choice about the amount of money they had to spend on medical care. This was particularly important for younger patients. Similarly, about 1/3 were not sure if they had enough personal financial resources like savings to cover the costs of their care. And such struggles do lead to measurable adverse outcomes across survivorship. There's an emerging body of research that's now identifying that cancer patients and survivors with financial toxicity have measurably worse quality of life, lower adherence to cancer treatment and general medical care, more missed oncology visits, more medical debt, credit debt, foreclosures, and bankruptcy. So it's imperative to discuss what strategies exist to reduce financial toxicity. I would say the model solution is ultimately going to require action at many different levels. And this involves not just patients and families, as well as their cancer provider teams, but employer, health, and insurance policy level interventions. And this is a figure adapted from Dr. Yabroff and colleagues that shows this idea of multi-level approach to reducing financial toxicity. But what I want to focus on today is discussing intervention focused at the patient and provider team level. I believe that in the context of delivering cancer care and survivorship care, helping patients to understand the ways that they can interact with their provider teams to connect to and obtain the best possible resources to address ongoing financial toxicity is critical to empowering patients and families in the face of this vast problem of financial toxicity. The current model of addressing financial toxicity in cancer care at this patient and healthcare provider team level is called financial navigation. So most of us are familiar with this concept of patient navigation. Patient navigators traditionally guide patients one-on-one through kind of the broad aspects of cancer care, such as communicating with their oncology providers, setting up oncology appointments, or interacting even with insurance companies during the processes of screening, treatment, and follow-up. So in financial navigation, there are some similarities. There's guidance and coordination, and this is aimed at providing education, information, resources, and referrals for direct assistance focused on patients' financial concerns. So ideally, financial navigation is going to be a team sport involving many different players with different focuses and expertise. Typically, social workers, or in some facilities and health systems, nurse navigators are often the first point of financial toxicity care, helping point the patients to resources to optimize their insurance or disability coverage, as well as assessing and coordinating other needs like for housing, transport, food, and other assistance. And they may help coordinate the referrals to financial counselors who might help the patient get an estimate on their expected out-of-pocket costs to help them plan or to actually help set up a payment plan. There are also referrals that can be made to pharmacy specialists who might facilitate patients obtaining prescription assistance for certain infusion or oral drugs, and connection to community or other professional organizations, which can provide help with practical resources, such as information or grants for transport and lodging. And these organizations are also critical for patients to connect with a network of other patients and survivors, and in that process have access to shared knowledge and support on how to navigate through the financial challenges of care. And finally, another important component of effective financial navigation is really the role of the clinical provider team, who as partners, they can support the aspect of streamlining and coordinating the clinical aspects of care with patients and families' practical needs related to treatment, such as the schedule, location, and goals of care. To highlight some examples of community and professional organizations, I think several of these have been mentioned before, but I think what's wonderful is the depth of online resources, including on the Melanoma Research Foundation, but as well as other resources more generally for other disease sites through, for example, American Cancer Society, Cancer and Careers, both of which have been mentioned today. But there are specific pages that help provide patients and survivors information and direction on financial, insurance, legal, and employment matters to address the key aspects of financial toxicity related to cancer care. And these sources of widely available information provide an opportunity for patients and caregivers to collect information as early as possible in their cancer care journey to be proactive in addressing financial toxicity. So combine these psychosocial, clinical, and community-based resource components comprise a so-called simple schema for providing cancer patients a pathway for financial navigation during the cancer journey by assessing patients for financial toxicity when they receive a diagnosis of cancer and begin treatment, navigating patients to obtain coordinated support resources, and ultimately helping to improve patient financial toxicity. In reality, what's important to acknowledge is that addressing financial toxicity is really not so simple. It's a reality that together, patients and healthcare providers, we really need to recognize in order to remember that addressing the financial impact of cancer is a process that needs to be revisited repeatedly throughout the cancer journey. And it's really not a one-time intervention. And that's because at diagnosis, for example, there can be an overwhelming amount of information and decisions that patients already face. In that context, it might be difficult for patients and their caregivers to fully recognize, articulate, and integrate their financial concerns with the members of the healthcare team and the intended treatment plan. And then just as patients' treatment goals may change and evolve over time, patients and their caregivers, families' financial challenges also change and evolve over time. For example, And it's just at different points in their lives. For younger patients, they might be initially covered by their their parents' health insurance, but then they might need to transition to obtaining their own health insurance as they become older, or they may encounter new financial concerns around aspects like fertility, having young children, or establishing a new vocation. I'm sure Dr. Roth is going to talk about some of these specific aspects to young adult patients. At the other end of the age spectrum, patients may come to a point of transitioning to Medicare insurance, where coverage policies may change their out-of-pocket burdens, and they need to reorient what they might expect for their financial burdens. Or they may have a spouse that's beginning to face their own medical issues, and this may change the overall household medical financial stress burden. Patients also might need to face a balance between choosing to obtain all of their cancer care at a single specialty center versus coordinating different parts of their care with local providers. And again, this may change over the cancer care journey. Different patients and survivors may face cultural and language barriers that importantly impact their financial status and understanding. And all of these are real world concerns and add layers of complexity to accessing even the most coordinated resources for navigating the burdens of the financial burdens of cancer and its treatment. And I want to recognize this complexity because formal recognition of financial toxicity and implementing interventions in different healthcare delivery settings is still kind of early and emerging more in recent years. So I would say not every healthcare setting has every one of these components of financial navigation well developed. And the standard of care for financial navigation is still developing. So I would say empowering patients, their caregivers, and the support network of survivors like the one here today to be familiar with this problem is intended to help patients proactively seek out navigation resources soon after diagnosis and then over and over again throughout their cancer journey. But the next frontier, the future frontier for advancing interventions for financial toxicity is going to be developing systems and strategies to target and tailor financial navigation resources to patients at multiple critical points over the entire arc of their cancer journey. And just as the landscape is continuing to evolve on cutting edge therapies to treat cancer, the landscape is evolving to discover the best possible strategies to reduce and address financial toxicity. So in the United States, there are multiple randomized trials that are ongoing to develop different ways to better deliver financial navigation to cancer patients and their caregivers. So in summary, my hope is that defining this problem of financial toxicity and the current stage of strategies to address it will promote its early recognition and early intervention. And this is because financial toxicity is a frequent, impactful problem affecting nearly half of cancer patients and survivors. Financial toxicity adversely impacts health and economic outcomes in these individuals. Financial navigation is the current cornerstone of reducing financial toxicity in cancer care delivery. But navigation requires the coordinated work of many disciplines, and this includes clinical and non-clinical healthcare team members, along with community and professional resources. And the landscape, I would say, is developing for navigation strategies. And this is continuing to evolve, and ongoing research is going to serve to advance interventions in this way. By engaging patients and caregivers and healthcare providers, like in this audience today, to recognize this problem, financial toxicity, as well as, excuse me, the existing strategies and resources to address financial hardship is going to be a step toward empowering them to confront this critical challenge in the cancer journey. And I really thank you for this opportunity to present today.
Thank you so much, Dr. Smith, for joining us and for such a great presentation. You know, one of the things that really struck me as you were going through is, in a way, it reminds me of us discussing sexual health in survivors, right? That these are issues that are so critically important to our patients, but oftentimes patients are either reluctant or embarrassed to bring these up, and that there are resources that are available. And, both between our clinicians and between non-clinicians, we want to help and we want to engage people with resources, but I just would encourage people to realize that there are resources out there and to please engage with the clinical and non-clinical teams to start to address these, especially too, as I realize that many of the people that have joined us today actually come from all over the country to seek care at MD Anderson, and beyond just the actual cost of treatment and what insurance doesn't cover. There's also the transportation, the lodging, and then of course time missed from work. So thank you. And with that, we will move on to our last speaker. Thank you everybody for sticking with us. Again, really unique resources that we have at MD Anderson, and one of these is our adolescent and young adult clinic. This is co-led by Dr. Michael Roth. His clinical practice is actually pediatrics and specifically with liquid malignancies, but he runs our adolescent and young adult clinic, and there are some really unique issues that these patients face. So thanks for joining us.
Great, thanks so much for having me. I'm going to share my presentation. And I know we're running a little bit over, so I will try to be efficient and get you guys back to your weekends and perhaps the Olympics as well. Thanks for the opportunity to talk about an often under discussed population. These are adolescents and young adults who are affected by all types of cancers. I do not have any disclosures. And just to give you a general overview of the population, so when we talk about adolescents and young adults with cancer, AYAs as well referred to them, these are patients aged 15 to 39. And this incorporates and encompasses a number of different developmental stages, as you know, which will be important as we focus on some of the areas of health-related quality of life that can be impacted by a cancer diagnosis. Cancer in AYAs is rare, although almost 90,000 AYAs are diagnosed with cancer each year. And a large proportion of those patients, about 8 to 10% of AYAs, are actually diagnosed with melanoma. When we look at cancer incidence and cancer types, younger patients in the AYA population are more likely to be diagnosed with leukemias and lymphomas. And as you get older into the 20s and 30s, more and more patients are more likely to be diagnosed with melanoma, colorectal cancer, and breast cancer. And AYAs actually represent a significant proportion of all patients who are diagnosed with melanoma, with up to 10% of all patients being diagnosed within that 15 to 39 year age range. We do know that the incidence of melanoma is or appears to be increasing within the AYA population, specifically within females. And it's not clear to me at least why, but there are many more melanoma experts who have been giving wonderful talks this morning who might be better able to address that issue. So I wanted to talk in general about our AYA population and some of the disparities in care that actually occur within this country. So we do know that adolescents and young adults are likely to receive their care in one of a number of settings. The younger age group is more likely to be seen in the pediatric setting. And as patients get older into their late teens and 20s, they're much more likely to be treated in the medical oncology setting. Specifically, AYAs are more commonly treated in community sites as opposed to academic sites. And this variety of sites does lead to some discrepancies in outcomes, which we'll see on the next slide. In diseases such as acute lymphoblastic leukemia and patients with brain tumors, we do know that where you get treated does impact outcomes. And specifically, we see that patients treated at academic sites are more likely to have improved outcomes compared to those treated in community settings. Unfortunately, we know a lot less about the impact of treatment site on health-related quality of life and survivorship, and we know very little about how treatment site impacts AYA outcomes in regards to survival and survivorship. I want to start to focus a little bit more on how cancer impacts an AYA's life, both during and after treatment. And it's really important to acknowledge that the ages of 15 to 39 really do cover a number of different developmental milestones that are quite important for patients' trajectory in their lives and their long-term health and their long-term quality of life. We know patients in their late adolescence. This is a time period when patients start to become more independent, try to do or start to do more things on their own, start to develop their education in terms of thinking about careers in college, and really sort of moving forward, exploring themselves in the world. Patients between 18 to 25, 28, this is when they become more of an emerging adult and they start to become even more independent and set up their career and start to set up their lives. Relationships, potentially finding life partners become more and more important, and starting out with a first job or developing the training that they need for that career become essential. And then we talk about young adulthood, which we are designating here ages 25 to 39. And this is when folks start to think more about that financial independence becoming even more important and developing a family and supporting their family. And you can imagine that a cancer diagnosis and a hit during any one of these stages can really impact a patient's life, both during that treatment as well as for the long term as we think about their life and career trajectories. So I like to think about all of the different areas in which cancer can impact a patient and a survivor's life. And you can see here, this covers just some of those areas. And it really is anything that's important to an adolescent and a young adult could actually be impacted by a cancer diagnosis. And this can both impact patients' lives and their quality of life during treatment and long after treatment. We look at domains such as fertility, where it's essential that we discuss these issues before patients start on treatment and offer the opportunity to preserve their fertility, because we don't know what treatments they may be getting or the duration of treatments, and they may miss that window of being able to have biologic children. When we think about areas such as body image, relationships, sexual health, as Dr. McQuaid mentioned, these are often topics that are not addressed by primary care providers or primary oncologists. And often primary oncologists are really focused on curing that cancer and obtaining the best outcome. And there's often not enough time to really delve into or dive into some of these issues. And within our AYA program, we try to touch on each of these topics, not telling our patients what we think is most important for them, but really hearing from our patients what is most important and most relevant for them, so we can fill in some of those holes and provide them appropriate support and resources. So specifically at MD Anderson, we have developed a number of resources for this population. And we developed this in collaboration with our Young Adult Advisory Council. So this includes patients and survivors who have been treated at MD Anderson, and they really guide us on what is relevant and most important to our AYAs. This is the front cover of one of our resource guides in which our AYAs told us what topics were most important to them, and the patients themselves developed this guide to help others navigate both cancer treatment and survivorship. As you can see, many of these topics are relevant to patients of all different ages, but specifically focused on those patients late adolescence and early young adulthood. Now I want to shift and talk a little bit more about late survivorship and late effects. And unlike most things in oncology where we learn from medical oncology and that moves down to pediatric oncology, survivorship actually worked the other way, where we learned about late side effects from treatment from pediatric cancer survivors, and then that has moved up into the medical oncology world. And late effects are what we define as those chronic or late occurring effects that could be physical, they could be psychological in nature, that persist well beyond 5 years from initial diagnosis. In the spirit of the Olympics, I wanted to list a few of those domains that can be impacted and can be categorized as late effects. And I really want to highlight here that all aspects of a patient's life can be impacted longer term, well beyond initial exposures to a cancer diagnosis and cancer therapy. Now, this is one of the seminal articles which came from childhood cancer survivors, and this included adolescent survivors as well. And what we learned is that over 2/3 of all of our childhood and adolescent cancer survivors will develop at least one chronic illness in their lifetime, and many will have additional chronic illnesses, more than one. In addition, more than 1/3 of our survivors will have at least one severe or life-threatening illness in their life post-treatment. Now, we have a lot of data, a lot of information on our childhood cancer survivors, but we have a lot less data on our AYA survivors. And that's one of the main areas of research which we're trying to fill the gaps in here at MD Anderson. We know even less about the long-term outcomes of our AYA melanoma survivors. We do know that physical health conditions is not the only area which can be impacted. For our childhood and adolescent survivors, we know that long-term quality of life domains, including relationships, insurance status, the maintenance of employment, having financial security, as Dr. Smith noted, these can all be impacted. And when you compare our survivors compared to their genetic and environmental match, their best match, their siblings, we see that our survivors actually have poorer outcomes on the whole compared to their siblings. And there are certain risk factors in this population, specifically certain diagnoses and certain exposures, which increase the risk for having more challenges later on in life. But once again, we have a lot more work to do, specifically understanding the long-term consequences for our AYAs, and more specifically for our AYA melanoma survivors. When we think about the psychosocial health of our patients, we think about a cancer diagnosis as being a trauma, and patients respond differently to that trauma. No matter how intense your therapy going through a cancer diagnosis, as all of you know better than I do, is traumatic. And this is a simplified version of what really happens for patients in life. But we do know that most patients fall somewhere on a spectrum where this life-changing event does often impact how patients proceed in their life, making important life decisions for their own personal health, for their careers, for their relationships. And some of these events result in growing from this event, but also for many patients, they struggle post-treatment. And this is really my plug to all of you that please, don't hesitate to seek out help if you are struggling or if you have friends or colleagues who are struggling. We all need help at certain times in our life, and having had a cancer diagnosis is definitely one of those things that predisposes many to having poorer psychosocial health outcomes. Concluding, at MD Anderson, we try to do our best to fill in the holes and fill in the gaps. And I was very lucky when I came here about 4.5 years ago that there was a lot of support to address this, the needs of our AYA population. So we focus on 4 main areas in our program. Specifically, we provide psychosocial support, career development, vocational counseling, educational support for our patients, oncofertility counseling and preservation before, during, and after treatment. We focus on genetic predisposition. So getting cancer is rare for a young adult, and we try to fill in the gaps to help patients answer of whether they have an underlying genetic cause of their cancer, and that often impacts decision-making for family planning and genetic testing for them and their family members as well. And then we see our patients long after treatment in our survivorship program to make sure that they're able to thrive and really achieve the goals that they set out prior to being diagnosed with cancer. So in summary, melanoma does represent a fair proportion of all cancers in AYAs, representing about 1/10 of all diagnoses in the population. We know that adolescence and young adulthood are critical times in an individual's development in life, and having a cancer diagnosis can really disrupt both their health, life, and career trajectories. AYAs diagnosed with cancer have unique needs, and we need to make sure that we address these unique needs and do not just treat them the same as we treat younger children and the same as we treat older adults. Physical and mental health side effects are real, and they occur in a high proportion of patients, and we need to make sure that we are educating our patients and addressing these needs. We strongly believe that AYAs with melanoma on treatment and off treatment would benefit and do benefit from specialized care and attention, and I encourage you guys to continue to seek out this care. And we do have a lot of work to do to fill in some of these gaps and these holes on the knowledge base and make sure that we're identifying, addressing the long-term health needs of AYA melanoma survivors. On that note, I'll conclude and say thank you to Dr. McQuaid and the organizers. Please don't hesitate to reach out to me if there's any other questions or things I can help with.
Thank you so much, Mike. Really interesting presentation and such a fantastic resource that we have here. I know that the patients that I've referred over to the AYA clinic have really benefited from that multidisciplinary support. So thank you for establishing it. And with that, we will now close our MRF MD Anderson Patient and Caregiver Symposium. I would really like to thank all of our speakers for taking time out on a Saturday to come and share their knowledge with us, and also for our amazing attendees for listening, for really great questions and engagement. The MRF, again, has numerous resources that they have posted about. We will also be sending out links to the presentation, and this will live on the MRF website as well. So thank you again, and we hope to see you for future symposiums. And then Amy, would you like to close us out?
Yeah, sure. I wasn't expecting that, but yes, thank you so much, everyone. Please, as Dr. McQuaid said, please visit the Melanoma Research Foundation's website, melanoma.org, for lots of resources and information. And we will also be posting this, as she said, within the next week or so. So please keep a lookout for that. Otherwise, have a safe and wonderful weekend, and we will see you hopefully in 2023 in person.
Thanks, everyone.